Good evening, tribe. I'm so glad you're here with us. This is Miranda, and she has specialized in bariatrics. So welcome, Miranda.
Hello.
Thank you for joining us after your long shift and giving us your time. There was a lot of interest around bariatrics. I know I mislabeled it. So tell us what it actually should have been labeled.
So my title is Bariatric Program Coordinator. You weren't completely wrong. I just didn't correct it because I thought, oh, that sounds kind of interesting.
Maybe that'll be a catchy title. No,
Right.
and so, okay, great. That's perfect. So just tell us a little bit about what you do and what prompted you or interested you in bariatrics.
So a bariatric program coordinator, what we do is we work with weight loss surgery patients before surgery. So we prepare them mentally. We do support groups where they can come and kind of find a home and kind of talk through some of like the lifestyle changes that they're doing. A big part of our job is education. So educating patients, but also educating family and nurses and doctors and just people in general on what weight loss is, that it's not just a quick surgery and not just something that's super easy. It's a lifestyle change. And so that's a huge component of bariatric coordinating. And then, of course, after the surgeries that they have, our job is to kind of be their cheerleader, like cheer them on, encourage them to keep moving forward. And when they have a setback, it's just a minor bump and keep going forward. I got into bariatrics because when I was a baby nurse, I really wanted to go to labor and delivery, and my hospital wasn't hiring any more interns at the time. And so they just kept saying, you know, get your foot in the door and you can transfer at 6 months. And that's really the bariatric floor was hiring. So I went there with the anticipation that I was just going to leave. And I loved it. You walk in the door, the patients are excited to be there. It's a lifestyle change. I was a cheerleader growing up and in college, and so I felt like it was like a perfect spot where you get to cheer people on to be better. And I would go into work every day excited, and that was 10 years ago, and I haven't left.
That's so awesome. So if this is something that nurses are passionate about, interested in, maybe on a personal level as well as on a career level, how do you recommend that they get started, and should they have prior experience? Should they not?
That's a great question. So with bariatrics, honestly, baby nurses are phenomenal. They come in, they have really raw knowledge, and so they're moldable. With a lot of locations have bariatric programs, and so if someone's really interested, if they go to like asmbs.com, or I think it's asmbs.org actually, or just kind of look at their local hospitals to see if they offer bariatric specific programs. You don't have to have experience to get started. In order to be a CBN nurse, which is a certified bariatric nurse, you do have to work with weight loss surgery patients in a hospital setting or a clinic setting for at least 2 years, and you do have to be an RN. They don't let LPNs sit for CBN yet, but we are trying to work on that because LPNs are nurses too. And so right now they only allow like registered like dietitians or registered nurses sit for that type of exam.
Okay, good. So we had tons of questions come in, and I think a lot of it was wanting some clarification based on the questions that came in, but also people are interested in it for their own personal use as well. So this is kind of be a twofold Q&A. And like I said before, we try and keep them under 30 minutes, but if more questions come in, are you happy to answer those when we're not on camera, if people put them in the comments, Miranda?
Absolutely, yes.
Okay, great. Okay, so first off, can you explain the difference between a sleeve and a bypass, the different operations that are available in bariatrics?
Yes. Okay, so a sleeve surgery is considered restricted. So what happens is the surgeon goes in and basically they remove the stretchy part of the stomach. So you're left with this like banana shaped kind of curved stomach. So it's about a reduction of 80% of the stomach. With that, you don't malabsorb. So everything you eat, you do absorb. It's just a much smaller amount. So you hold 4 to 8 ounces of food at a time. A gastric bypass is restrictive and malabsorptive. So the restrictive part is the upper portion of the stomach becomes your new pouch, and it's like about the size of your fist, like a large egg. And then
Okay.
the duodenum and the jejunum are switched. And so that's where you get the malabsorption. So instead of the food going through the mouth into the stomach and going through the duodenum is bypassed. And so your fats and your sugars, which would absorb there, you're not having that absorption. And so those patients typically have greater weight loss because when they, like if you have diabetes, when you eat something that has sugar in it, your body's not absorbing it, and so it's kind of passing through quickly. And so if you don't make a lot of insulin and things like that, it actually helps with diabetes because your body doesn't have that sugar component. We also
Mm-hmm.
have something called a duodenal switch, and it is a sleeved stomach but a rerouted intestines, kind of similar to a bypass, but you reroute the lower portion of the intestine instead of the upper. There's band
Okay.
procedures. A lot of places are kind of going away from the band just because typically patients who do have a band, they work really hard for weight loss and they rock it. But it's hard for some of them to have lifelong success. And so they're sort of phasing it out. Some facilities do them, but not a lot. Um,
So, what's the correlation between the band and the lack of success?
I think with the band is that if you aren't going to the physician's clinic every 4 to 6 weeks for a fill, then we're not doing anything to the stomach underneath the band. So there was a procedure called plication where they kind of pushed the stomach in and they sutured it so it looked like a sleeve, but it wasn't. But you still have all that ghrelin hormone, and there was no full trigger really, other than the band stopping the food. And so over
Okay.
time, patients, would go to like liquid calories, like milkshakes or sodas and things like that that go in really easily, but they're high calorie. And so if you stopped eating properly or stopped exercising really hard, you didn't have good success, and you weren't
Mm-hmm.
going to constant visits, lap band fills are very costly. So some insurances don't cover them, and depending on your location and what state you live in, most of the time it's like $200 a fill out of pocket. And that's expensive. And that's a commitment that some people aren't told about prior to a band. And so they can't financially keep up with it. And so they just have these longer periods without a physician coverage. And usually that leads to hunger, and they kind of, they gain a few pounds and then they're upset and it just kind of dwindles down.
Okay. So, during our exposure about this event on the tribe, we had a lot of maybe misconceptions, might be the right word for it. Could you clarify some of the misconceptions that people have, maybe not just in the tribe, but overall umbrella misconceptions about bariatrics?
Absolutely. So the biggest things that I see and hear kind of in the outside of the bariatric community is that having a weight loss procedure means you're weak, that you're taking the easy way out. A lot of people will say, well, if you can eat a bariatric diet and lose weight before surgery, why have surgery? Why not just eat that
Sure.
way or exercise for the rest of your life? And the reality of that is that it's not a diet that you can sustain for a long periods of time without a tool to help you stay there. And so,
Mm.
eating a high protein, low carb, low sugar, low fat diet isn't hard, but it's hard to stay there if you don't have something that helps you with restriction. A lot of patients, their family members. I won't say anybody's name, but I read the thread with the questions, and
Yeah.
a lot of medical providers actually have negative perceptions of weight loss surgery. And it is usually due to the area that they work in. So, like ICU nurses, typically see really sick patients. And so, unfortunately, when a bariatric patient goes bad, they go to the ICU. And so, not that it's really their fault, but their culture of the area that they work in sees really bad things. And so, their perception of bariatrics is that it's terrible.
Yeah.
And that's been something that's kind of was a passion of mine, even in the facility I work at for a short period of time. When you asked the ICU nurse about weight loss surgeries, you heard terrible things. And it wasn't that they really truly believed it, but in their field, that's what they saw. And so
Your
I've seen that.
perception is your reality, right?
Yes. And even some physicians, some primary care physicians or ER physicians, have not realizing I'm a bariatric coordinator, have said some really terrible things when they find out I work in bariatrics. And then I'm like, wait, hold on. But it's usually the environment they're in that kind of they might see one negative thing, or a family member may have known somebody that knew somebody that had a complication, and they just stick with that. And that's one thing really awesome about a bariatric coordinator is that I get to see you before, during, and after. And like floor nurses and ICU nurses and even physicians that aren't bariatric surgeons, they might only
Sure.
see you at one point of your journey, not through the whole thing. So they might
Yeah.
see the bad and not the great things that happen after.
Okay, so let's move on. What's the criteria for the surgery? And I know that varies a little bit based on your insurance plan and the physician that's doing the surgery and all of that stuff. But I guess maybe just speak on either your personal experience or an umbrella of what you know is true.
Sure. So for all weight loss surgeries, whether you're having a band or a duodenal switch, which is a little bit more invasive, MBSAQIP is the accrediting body that works all over the world with weight loss surgery patients, and they're kind of who gives us our guidelines. We used to,
Okay.
Joint Commission used to mandate our rules, but now it's MBSAQIP. And so
Okay.
their criteria for any weight loss procedure is that they just don't want any surgeon out there doing surgery on patients that shouldn't have it, because we don't want them to be malnourished or have the complications that people hear about. So
Okay.
if your BMI is 35 or less, like 30, above 30, but less than 35 ish, usually those patients would qualify if they're, depending on insurance, if they're diabetic, if they have PCOS, if they have sleep apnea, if they have hypertension, high cholesterol. You have to have two comorbidity
Okay.
listed with complications, medications, things like that. If your
Mm-hmm.
BMI is 40 or greater, you don't have to have comorbidities because your weight alone qualifies you. And
Okay.
so insurance looks at that first. If you don't meet that criteria, then you could fall into like a cash pay option. But again, there's still criteria for that. And every program generally has to follow the 35 BMI or higher. But again, some locations offer different packages. And so that number might be slightly different based off of medical history.
Okay. And then Pamela asked, do you just prepare or counsel the patient, or do you involve the spouse or family in what to expect as well? And I just want to make a comment to the viewers. You guys ask questions, put them in the comments, and as we're going through, I'll ask the questions to Miranda as it's appropriate and fits in the conversation.
So that's a great question. So, so I'm a bariatric coordinator, but I'm also a weight loss surgery patient. I had a sleeve in 2013. And so
Awesome.
I was a charge nurse first for the bariatric program. In 2014, a year after I had surgery, I became the coordinator.
Oh,
So,
wow.
yeah, so sorry, I know that's kind of a long answer. Prior to
No,
me,
that's great. That gives people a really great perspective. not only did you work on the floor and then you became the charge nurse and then you were a patient and then you were the coordinator, I feel like it gives us a really great, well-rounded view.
Sure. Okay. Thank you.
Yeah.
When I became the coordinator, I kind of turned my role a little bit based off of personal experience, and I kind of looked at my journey and what I felt would be helpful or more helpful for patients moving forward, kind of some of the pitfalls or some of the things I really thought was great, but maybe we could make a little bit better. And so we didn't do a whole lot with family focus when I was going through the journey. And I know that a lot of my friends and families had questions and reserves about all of it. And so I made a point to involve families. So we do encourage family to come to support group meetings. We encourage them to come to the patient education. We do a preoperative class. And we love when family comes and we try to involve them. A lot of times, if a patient is saying, their spouse is really concerned or doesn't want them to have this procedure, I have them give them my phone number. I'm like, please have them call me. So I try to walk them through, and most of the time, it's the lack of education and they're just afraid for their family member. And once you can educate them and things like that, it's so much better. So we do try to involve the family. The only aspect we don't is the when they do the psych eval, that's a one-on-one.
Okay.
They can't do that. And so we do that.
Okay. And there was actually, since you mentioned the psych portion, there was a question that came through. Oh, it's the next question I have on the list here. Kathy asked, do you believe the psychological aspect is addressed enough? And I know after reading some of the comments that came through, it sounds like the criteria or the psychological eval used to be more strict, or I'm not quite sure the verbiage to use there, a longer process than it is now.
Yes. I saw that comment and I was like, oh, I love it. For the psych eval years ago, some programs did a really good job with making sure that patients were followed from beginning through the end. Unfortunately, personally, there is only one mandatory visit prior to surgery for most programs.
Oh.
And it's basically your workaround and your clearance for surgery. Again, MBSAQIP, they're trying to do best practices and kind of what works best. And so they have been talking, and our program personally has been talking, that we feel like patients need more after. Before is great, but after is really where, one of the nurses on this feed had said that they feel like the surgery is more psychological, and it's absolutely correct. The surgeon does the tool and the change for you really quickly. And then after surgery, you have to take months and months to get your brain and your stomach kind of on the same page. And so the psychologist would be so helpful for that. But it's not mandatory. It's optional. And some patients are afraid to reach out.
So what is the psychological eval? What is it like? What are they looking for in these
It's 50 pages of paperwork that you fill out. It's very it's time consuming to fill out this paperwork. And honestly, and I don't know, the psychologist, she won't really tell me which, questions, but they're only looking at 5 questions in this entire packet. So
Oh my God.
they're trigger questions. So basically what they're doing is, they're wanting to make sure you don't have active, like eating disorders or active, like drug problems or alcohol problems or anything like that. So they're definitely looking for that. They're looking that you have a way to cope. Like, what's your coping mechanism? Is it healthy? Is it moldable? Do you have family support? They're kind of looking at those things. And so beyond that, I'm not 100% sure what they're looking at, but I do know ultimately they want to know that the patient is mentally prepared, that this surgery is going to be a lot of work, that you can be successful and great life and a healthy life, but it's also going to take a lot of work and a lot of dedication. So that's a main key factor that they look at, is that you're ready.
So you mentioned the element of addiction, and is it a misconception on my side that it's an addiction to food? Is that not true?
I mean, it can be for me personally. Like if somebody had asked me previously, do you have a problem with food or are you a comfort eater? I would have said
Yeah.
no. And I did say no, hands down. But personally, after having weight loss surgery for me in the beginning, oh my goodness, yes. Like if I was
Okay.
really tired or upset or emotional
Yeah.
and I needed to like cope, I couldn't go to food. We take that coping mechanism completely away from patients, and in the very beginning that's where they struggle the most, is if they're like me and they don't identify themselves as a comfort eater and they are, oh boy, you're going to know it like right away. I mean, they're calling you, they're upset, they're angry that they can't eat, and that's a huge component to that. And so we, as a coordinator and our team, we really try to get patients to focus on what are your habits and what are your coping mechanisms, and we try to have them make like an alternate or other tools to help them through that. So it's not a misconception.
Before surgery?
Yeah, to
Okay.
prepare them for the potential after. So it's not a
Okay.
misconception. It's almost, I mean, like it's not right, but it's not wrong, because not everybody who's overweight has a food addiction. It could be
Okay.
genetics, it could be comorbidities, it could be any type of health condition. But for me, it really was that. Being a nurse, we go all day without eating. And then I would come home at night and eat like a day's worth of meal and then go to bed,
Right.
And so
Or the
that's
night
where,
shift, you're shoving your food in your face because you're exhausted.
yes,
Absolutely. Hands
absolutely.
down. All right. So let's see. The next question was from Pamela. She says, what type of patients do you feel have better success in weight loss surgery? Is there a type of patient that seems to be really successful?
To be quite honest, the patients that are most successful are the ones that have tried it all previously. And then they're ready, they're prepared. It is like, this is almost not really the end all, but they've, maybe diet and exercise. They've seen both sides of the world. They've seen what it feels like to be healthy, and then they've seen what it feels like to be at their highest weight, and they are just ready and determined, and they have a great support system. Those are the patients that typically do better. Also, patients that are willing to stay connected and be involved. I know that sounds really
Mm,
cheesy, but staying connected in support groups and doing regular visits with your bariatric team, your surgeons, your PAs, your practitioners, you're going to be more successful because you're almost like you're accountable to them, but to yourself. And so if you
sure.
know you're going to check in with them and you maybe up 5 pounds, you're starting to evaluate, well, where did that come from? And it keeps you kind of honest.
Sure. You mentioned having a Facebook support group. Is that exclusively for your patients, or like can people that need bariatric support in the community reach out to you?
That's a great question. So I started it originally for patients who didn't want their family and friends to know that they had weight loss surgery. So it started as a private page. And, I had some family members that were pretty low key about it. And it kind of blew up from there. It's almost 4 years old. And I have actually told family and friends of weight loss patients, hey, if you want to learn, if you want to come and ask questions, I've encouraged them to come on. So my group isn't just the
Awesome.
patient, it's the family members, it's a friend, it's a coworker. I have quite a few nurses who, like a nurse on our thread the other day, who really just wanted to come and learn. They had this negative perception of weight loss. The only thing I ask on that page is that it stays there. There's no negative, bantering, no food policing, just be kind. And they've learned a lot. And I've had lots of family members who absolutely love the page, and they're probably more active than the patient just because it
Okay.
helps them feel connected too. And even though they didn't have the surgery, they're learning.
That's great. I know there's several nurses that are talking about potentially getting the procedure done. So after, if you would please in the comments share your Facebook group so that those people can get connected directly to you. That'd be
Sure.
awesome.
Yeah.
Great, thank you. So Kathy asked, we're running close to 30 minutes and we still have 6 questions. So I'll try and go fast.
I'll talk faster.
And if you want to cut off before we're done, I can message you the rest of the questions as well. How do you feel like patients have adjusted post follow-up? And that was submitted from Kathy.
Oh, they adjust well. I think in the beginning, it's just a lifestyle change. So trying to figure out how to live their life with the diet. We prepare them before surgery, but after surgery, when they get home and they go back to work or their kids' activities, sometimes it's hard for them to adjust. Being, maybe they're out somewhere and they can't eat every 2 or 3 hours, and so they just really have to hone that in. But they adjust really well. Our program sees them really frequently. The first 6 months, they're in there at least once a month or so, about every 4 to 6 weeks. And so we try to catch any issues that they may have in the beginning. But they do really well.
Great. And then please share your favorite success stories.
Oh, I actually have permission from patients. I have before and after photos. After this, I'll post them to the thread so you can see that, I have patients that are doctors and nurses and, that have shared their photos. And just today I was taking care of a patient and she had surgery last year and she started at like 430 pounds and she's down to 300 pounds. And like we were high-fiving the, huge amount of weight loss. And, she was saying she's not at goal weight, but how amazing to lose that much weight just working so hard and the smiles. But I have tons of success stories. And I'll even share my personal before and after on here for you guys to see. It's definitely life-changing.
That's great. I'm proud of you. Good job. So what are the most common complications post-surgery?
Great job. So usually really small is nausea, vomiting. Nausea is probably the number one reason that patients come back through the ER or they need to have IV fluids from dehydration. Because what patients don't realize is that when your stomach is swollen, it's hard to get fluids in. And they're eager to exercise because they're trying to lose weight. And so they're drinking maybe 8 to 12 ounces a day, but they're trying to walk for an hour. And so they're not able to hydrate. And once you get so dehydrated, they have to come back for fluids. DVTs or PEs are pretty common. Most programs, like our programs, we do a lot of things to help prevent it, but the reality is it can still happen. And so, SCDs, incentive spirometry, ambulation within 2 hours of surgery, Lovenox injections or heparin, we do those things to help kind of prevent blood clots. But with some of the patients, their mobility is limited. It just puts them at a higher risk and their BMIs are higher. Leaks can happen. And the big thing that I want to say about leaks is that it's not always the patient's fault. So when a patient goes home and comes back with a leak, sometimes they're ashamed or they feel like they did something wrong when they didn't. Sometimes leaks don't even present for 2 or 3 weeks until the swelling is gone. It's just not there. The swelling is holding it closed, and then it goes down and you might have like a gap where the staple line is. And it's could have been a misfire of the stapler. It could have just been the way that the stomach was stapled in the beginning. And so it's not anyone's fault. It just could happen.
Okay. That covers it. How many days are people in post-op? Is it 24 hours, 24 to 70? 24 hours?
So if you are a band patient, you go home 4 hours later. If you are a sleeve patient, you go home at about 23 to 24 hours. And if you're a bypass patient, it's 2 days. And then usually duodenal switches, because they're more involved, they stay for 2 days. But that's just Oklahoma. Texas, lots of states, all of those surgeries go home same day.
Wow.
Yeah.
I know in New Mexico, they don't go home same day. For sure bypassed and maybe banned. I don't know about that banned, but bypass I know is 24 to 48 hours, I believe. But
Gotcha.
anyways, Lucinda asked, what are the qualifications for your job and what exactly is your job title?
Okay, so my
You
job
already
title,
asked that a little bit, but you can go over it again.
oh, gotcha. It's okay. It is a bariatric program coordinator. And so your duty, you kind of act as a project manager for the bariatric program. So I'm a liaison between, I'm housed in the hospital, I'm paid by the hospital, but I
Okay.
also outreach to the clinics. So I do education at both clinics. I work with an MBSCR, which is a metabolic and bariatric surgery clinical reviewer. So she does all of the
Okay.
data. And together we do all of our program certifications. So insurance verifications, any of our like joint commission, any type of surveys go through me. Um,
Okay.
every 3 years we have to do an accreditation, and so I do that. It's huge. It takes days and weeks for an 8-hour survey, and the main component really is just the outreach. It's not just for patients. I go to primary care physician clinics and I do outreach with physicians there to kind of educate them on bariatrics because they don't get that in their training either. um,
Wow.
I it's a lot of education and a lot of cheering. And so I can list a common JDP for them to look at. It's very rewarding job. It's a lot of work. It definitely takes heart and commitment, but it's very rewarding.
That's awesome. And then Pamela asked, what's the most rewarding part of your job? Do you have a specific?
The thing I love the most about it is patients, like seeing them in the hospital, and they'll have what we call buyer's remorse, where they're kind of like, why was I think what was I thinking? They're not feeling well, and then a month later, they're coming to their follow-up visits and they're so excited. And on my Facebook page that I run all the time, patients, which I feel is really small, I do give them my cell phone number, and I also tell them, if you have needs, private message me, and I respond within 5 minutes. And they're always, they're very, thank you so much. Miranda's so awesome. She's so available. And I don't do that for them to say those things. That is so rewarding to me, just to be a behind the scenes person trying to make a difference in somebody and letting them know that they are the ones doing the hard work. I really am just getting to be a part of their journey, which is a blessing, and kind of see them transform into their better person. And that's the part that I absolutely love.
Your passion just like floods onto the screen. I can just imagine being face to face with you. It's so cool. Okay, the last question, and we'll let you go. I appreciate you talking to us post shift. Lucinda asked about the certification, then asked about how you prepared for the exam. So if you just reiterate, I know you mentioned the certification earlier.
Yeah, so the CBN, it is on it's asmbs.org. On their site, they actually have all of the information, and I can tag all of this in there so people can go and see it. But
Great.
they actually have a review course that is on there. They do, you have to work with bariatric patients in some sort of setting for 2 years to qualify. And usually your surgeon or somebody who works with you in bariatrics will write a recommendation letter. And then you
Okay.
basically just sign up for the test. It's an NCLEX, but just bariatric specific. I don't have my name badge, but they send you like a little pin, and your credentials change. So like when I sign stuff, it's Miranda Matlick RN, CBN, or RN BSN CBN, So you can add
Sure.
those credentials, and you have to re-credential every 4 years. So it's not
Oh,
something
well.
you get that just goes with you forever. You either have to do 80 CEUs for bariatrics, which is very costly, or you retest every 4 years. And
Okay.
so I'll link all of that information, and it kind of gives you a study guide. And
Awesome. Link it here in our Q&A if you don't mind.
Yes.
Just stick it as a comment. Awesome.
Yeah, I'll link it there. And even if you don't want to test for CBN, the information is there's tons of information that's really helpful to learn and be able to kind of help bariatric patients.
Okay, I know one of our nurse practitioners that's in the group, she had some questions for you, and she was messaging me that her connection's been funny throughout the Q&A and she hasn't been able to get her questions answered. I already told her that you would be happy to talk to her. That was before I officially asked you. But anyways, I knew that you would because I could just tell. But anyways, she will contact you after the Q&A.
Perfect.
Awesome. Thank you, Miranda. I can't express how great it's been to learn from you, and I know the tribe will be super grateful as well.
Thank you guys.
Have a great night, okay?
You too.